at traumatic brain injury. Okay. So now I'm going to start getting a little bit more physiological here, but I'm going to try to give this to you in stories where the clinician can understand it and the patient can relate to it.
It's 11 o'clock.
Okay. So in this story, we have traumatic brain injury, bam. Now, we do have labs now that can do genetic or genomic sequencing and tell you which genes you have that will make it to where you will either go into a neurodegenerative component or not heal or will heal. I will not go into that in this lecture, but I will in the future, and it is astounding. It is absolutely amazing stuff. We also have autoimmune markers that will tell us if your injury has allowed the blood-brain barrier to be disrupted. You can see it down here. The blood-brain barrier is disrupted, and as a result, you end up getting immune cells that come in and create antibodies to tissue. So we can combine those two, and then we can look at either imaging, QEEG, or we can look at other balance testing and eye testing, and we can determine where your brain is not functioning, what's going on in the physiology, what's going on in the immune system, and which genetic components you have that take you from mild traumatic brain injury and pull you into post-concussive syndrome. Every single day, I learn something new about this, and it blows my mind. There are no two patients that are the same, and the people that are in post-concussive syndrome are desperate to get back to normal. And since they were mild, they should be normal, and if they're not, sometimes they're called mentally ill. When they're not, they're just still suffering. So let me run through this picture. This is one of my favorite pictures. I don't want to hurry through this. Let me tell you some of the things that happens, okay? So when we have a head injury, tumor necrosis factor, which is kind of one of those substances that's released by glial cells, okay? And I'll talk about glial cells here in a sec. But the blood-brain barrier can break down, and then the gut barrier breaks down at the same time. Usually within 20 minutes to several hours, we see these two barrier systems, they start to break down. So your barrier systems break down, so now white blood cells are moving in and out of compartments that they shouldn't be moving in and out of, which means you can get inflammation in your brain from your body and so forth. And then there's things in your brain that can escape out and can be measured, and that can be utilized as a way to determine, in part, if you have a leaky blood-brain barrier. Okay, so we have labs for this stuff. It's pretty cool. If this goes on, all kinds of things can happen. And then we know that blood volume goes down, so you don't get as much blood to your head. You start getting metabolic disturbances, and ultimately you get excitotoxic. So I'm going to explain a little story here real quick, okay? You have an excitatory neurotransmitter called glutamate, and then you have an inhibitory one called GABA. And I think most of the people in the medical world know those, but people who are patients, they really don't. So glutamate makes you excited. GABA slows you down, okay? When you have a head injury, the receptors for GABA internalize, and for glutamate, they are more excitable, so you can't sleep. You become hypervigilant. You become very sensitive to sound and all these different things. And a lot of that has to do with changes in brain structure, but a lot of it also has to do with neurochemistry. So one of the things that we do not want to do, so this is clinical tip number 1, with head injuries, we do not want to give excitotoxins. And excitotoxins are things like artificial sweeteners, aspartate, glutamate, okay? We don't want to give MSG, monosodium glutamate, because the cells, they're losing their glycolytic pathway. They're starting to apoptotically spill glutamate, and now everything around it is becoming hyperexcitable. There's not as much vasculature to it, so it becomes higher or closer to threshold. And so now things spontaneously depolarize, and you may see things like seizures, okay? So we know the GABA goes down, and this is one of the reasons why a lot of people end up on benzodiazepines like Valium or Ativan or alprazolam in order to slow things down, because they don't have any GABA and their brain is just going like crazy. Some people have been hitting the head so hard their brain just doesn't work anymore. It doesn't become active anymore. So they use stimulants like modafinil or methylphenidate or Adderall or different ADD drugs. So the world of pharmacopoeia It's so amazing. We're either trying to stimulate that brain or we're trying to inhibit that brain. But the world of the functional provider and nutrition is trying to help heal that brain faster. So now I'm giving you the differences in the paradigms. I'm giving you the definition of each part of that quilt. All right. So when we get excitotoxic and we have damage to the brain, we start activating something called the glial system. So we already know we're excitotoxic. Everything's going crazy. Okay. The glial system does this. There's 3 glial cells. There's microglial cells that have about 4 different ways that they're activated. And they're the immune cells. They're like the macrophages of the brain. They're putting out the fire. They're cleaning up the mess. They're pruning things. They're making synaptic connections. They're the artists of the brain. They're sculpting it, okay? And then there's the astrocytes, and they're recycling things and protecting the blood-brain barrier. And then there's oligodendrocytes, and they're covering all the wires like insulation so that you don't short out or get diffuse axonal injuries, even though that can be anatomical in itself, okay? When we have a traumatic brain injury, we get excitotoxic, and then we start to get the activation of microglial cells. So they deal with inflammation. So what that means is this: they're putting out the fire. And they have to do that, because if they don't, they have to get rid of the cellular debris, or we will get a DAMP or a PAMP. And a DAMP creates an immunological response that can drag in immune cells that will eat it and turn it into a moment where those cells are now antibody antigen moments. So if we don't get rid of dead debris because you hit your head, macrophages will sneak in, eat it, go down to a lymph node, stimulate a naive T cell, and you will make antibodies against it. And now you have brain autoimmunity. So now every time you're inflamed, you reconcuss. Post-concussive syndrome. Mild traumatic brain injury, post-concussive syndrome. So I already told you to get rid of the excitotoxins, lower stress, okay? You need a little activity depending on where the lesion is. But when it comes to neural inflammation, the only time we put neural inflammation out is when there's so much swelling in the brain, we have to get rid of it because there's intracranial pressure, and we use things like mannitol or maybe furosemide or Lasix or whatever the case may be. We use a diuretic to kind of shrink the brain up, or there may have to be some sort of craniotomy or something where there's a hole put in the head so that pressure is allowed to escape. Now, that would obviously not be a mild traumatic brain injury, okay? So don't stop the neural inflammation or any of that stuff early on, because the glial cells are cleaning up the debris. So if we stop that too soon and you have an infection, it creates a problem like a latent HHV6 or HHV7 or cytomegalovirus or Epstein-Barr virus infection, which we test for, because if they're there, it will create problems. Let the glial cells do their thing for at least 3 to 4 weeks, clean it up. The one thing that'll happen, though, is when the microglial cells get activated and we make inflammatory cytokines, it ends up creating oxidative stress in the mitochondria, which makes energy in the brain. It shuts down. So we get rid of the excitotoxins, 1. Number 2, we support the mitochondria with antioxidants so that you have energy and you can survive the damage. And then as time goes on, we eventually start to slowly decrease that inflammatory response so that we give you time to clean up the party, so to speak. And that's the damage. The pathway, the glycolytic pathway, starts to get distorted. So we don't push a lot of sugar, and we take people to the point of where we use exogenous ketones like BHBs and MCTs. BHB salts will take you more to ketones, and we'll use a different pathway for energy, and the medium chain triglycerides will help with that as well. So we don't have to use a broken down glycolytic pathway that will feed into a Krebs cycle to go to alpha ketoglutarate, which makes glutamate and causes excitotoxicity. So to the patient, don't have the excitotoxins. Find a doctor that can help you with oxidative stress. Then find a doctor that can give you the right diet where they fast intermittently. It helps with autophagy. And then it cleans out the cells. And then we don't push that glycolytic pathway that's already broken. And we can go not into ketosis per se, but use ketones as energy and not try to push it and ram it down a glycolytic pathway that doesn't work. And then we can do intermittent fasting, which makes all those mitochondria undergo revitalization, and it gives you energy. And then we cut the calories down a little bit as well. I just gave you like a ton of nutritional nuggets, and medication doesn't do any of that, okay? So we do all that, and now we can give some things that deal with the ischemia, and vinpocetine helps vasodilate. It helps with endothelial nitric oxide, and it helps reduce the inducible nitric oxide, which is inside the cell and makes it be destroyed. So a little vinpocetine, some antioxidants, get rid of the excitotoxins, wait on the glial cells, because if you don't, you may make it to where it doesn't clear out the debris, and now we get more brain autoimmunity. So if you do this the right way, you may save somebody down the road from having another condition. So this picture right here, when I first saw it, I was like, wow, this explains so much to me in regards to understanding a traumatic brain injury or an extracranial traumatic event. So really, really cool. Now, one last thing. These microglial cells, again, I already told you there's multiple pathways. I want to give you one whole lecture on microglial cells. But these microglial cells, they, again, are like the artists of the brain. They put out the fires. They synaptically prune things. They connect things together. Some people even say that they allow action potentials to jump from one pathway to the other. If we damage them or we hit the brain, they'll stay on for several weeks before they go off because they're cleaning things up. So no matter how good somebody feels, they've still got microglial cells typically that are on. And this is one of the reasons why we try to keep people out of athletics for at least 3 weeks if they've been concussed, no matter how they feel. Because if you get concussed again or have another mild traumatic brain injury while those are still on, now they stay on 16 weeks. More inflammatory cytokines, more brain volume loss, more neural inflammation, longer symptoms post-concussive patients. Clinicians, you can't get rid of it. If you get another head injury during that 16 weeks, now they may never turn off, and now they're primed or ramified and they're changed, and you can't make it go away with traditional medical model paradigms. And when that goes on long enough and you lose cell volume, you end up getting something like maybe chronic traumatic encephalopathy, or you trigger one gene that triggers 100 other genes, and now you have this neurodegenerative illness or another neurodegenerative illness. We're showing that traumatic brain injury, depending on your genome, will trigger a cascade of genes that will turn on one condition after another until you get to the point to where now you have inflammation, now you have autoimmunity, now you have genetic sequencing turned on, and it all leads into a big quagmire called a neurodegenerative illness. And it happened from that moment when you got a little head bang. Okay, so that's what this beautiful slide reminds me of. And I want the patient to get it, and I want the clinician to get it, so that you guys can communicate with each other. And patients, you don't feel isolated, and clinicians, you don't feel like you have the capacity to help some of these people when you really do.